Sharif, the Vice President of the Pakistani Neurosurgical Society, and also the organizer of the WFNS committees. We will talk, Dr. Salman Sharif will talk today about the craniocervical junction surgical approaches. Professor Salman.
Thank you, Ahmed. First of all, I'd like to thank Ahmed for his untiring efforts during this time. I again thank all the societies which are participating, Pakistan Society of Neurosurgeons, I think also WFNS Young Neurosurgeons Forum, you know, basically everybody together have done a great job, and I'm grateful to the Yemeni Society for same. Let's start. And I was supposed to give this talk, I think, ages ago, but for various reasons, I'm giving this talk in the last session. So here we are. There we go. Today, I'm going to be talking about anatomy and approaches for CV junction. This is one of the famous lakes in Pakistan, which is about 4,000 meters high, and it's an amazing place. Hopefully, you guys can come here to this place one day. So let's start. A 27-year-old male, history of a road traffic accident at the age of 15, 12 years ago, type 2 odontoid fracture and quadriparesis, was managed conservatively at that time. Improved neurologically over time. This time he presented again with road traffic accident when his head collided with the dashboard. On examination, his DCS was fine. Powers were on the right side were normal. On the left side were 4/5 proximally and 3/5 distally. In lower limb, there was no power. This was his scan when he arrived. Again, you can see a type 2 fracture there. And this was old fracture and semi-healed. But when we did flexion extension X-ray, the whole C1 went forwards, suggesting it's unstable fracture. So type C2, non-union, type 2. And what we did was a C1 lateral mass and C2 translaminar screws. Power improved 4/5 at 3 months, and at 6 months is back to normal and doing his routine work. This is the C1 lateral mass and C2 translaminar screw. And this patient was reduced in neutral position. So odontoid fractures, we know about these. They are type 1, 2, and 3, and this Dennis classification is very old. 1 is stable when there's avulsion of the tip. 2 is unstable when there is fracture at the base of the dents. This is the most common, and this requires surgery in majority of the cases. Type 3 is unstable fracture at junction of odontoid and the body of C2. Then Grasper classification, which just divides that into further 3 types. That type 2A is undisplaced, depending on if there's displacement or not, and if it's displaced transversely or anterior superiorly. So, you know, we are going anterior to superior to anterior superior to posterior inferior. So it's going in the direction that would be ideal to put in a screw from below. And then type 2C is comminuted or anterior inferior to posterior superior. In other words, the fractures line is going against in the direction of the screw if you put in a screw from front. So then it will be very difficult to correct this kind of problem with anterior fixation. Let's go through the anatomy of CV junction. We're going to be talking about bones, joints, ligaments, nerves, and vessels. So let's take bones first of all. And I take occiput first. So this is this bit, which is the posterior and superior to the foramen, is the squamous part of the foramen magnum. And its basal part is anterior to the foramen magnum in front, which includes condyle and the clivus. And the thickest part of the bone is here, and it helps us when we want to put in occipital screws right in the middle. When we come to atlas or C1, so there are 2 lateral masses on both sides, situated in the anterior medial part of the ring. There's a short anterior arch, as you can see here, and the long curved posterior arch. Foramen transversorium is lateral to the articular surfaces on both sides. Superiorly, there is the facet, which is oval and concave, and faces upward and medially, whereas inferiorly facet is circular, as you can see here, and flat forward faces downwards and medially. And the idea is that, that depending on what movements we need here, so that's how this particular bones are made. Sulcus arteriosus on the superior aspect, as you can see here. And then vertebral artery turns 90 degrees. So it comes to a complete 90-degree angle after exiting into the sulcus arteriosus. Generally speaking, vertebral artery is 1.5 to 2 centimeter from the midline. So that's safe to take that part of the bone if you need to take it. Whereas C2 or axis has a dense or odontoid process which is sticking up. There is a pars which is right in front. So pars basically is between the two articular process, superior and inferior. So, and we talked about the superior facet is oval and faces superiorly and laterally, and round inferior facet faces inferiorly, anteriorly, and laterally. There's a transverse foramen on both sides, and that's lateral to the superior articular facets and anterior to the inferior articular facets, as you can see here. So lateral and anterior. The transverse foramen is directed superior laterally to allow lateral deviation of the vertebral artery going out and then coming back in. Pars interarticularis, as we said, is between superior and inferior articular processes. So it's between the two articular processes is the pars, whereas if you see pedicle is all the way in front. It's laterally bounded by transverse processes, extension. In extension, there's significant strain on the facets due to offset of coronal orientation, disproportionate length, and then you can get Hangman's fracture in C2 vertebrae. The foramen itself is lateral to the pedicle, as you can see in this, and it's angulated 45 degrees lateral, partially roofed by superior articular process, as seen here. The joints, the occipital-cervical joint is occipital condyle and superior articular process of C1 make that. And I think it's important to remember that it's always has to be smooth and should not be forward, backward. And whenever there is, then you can think about some kind of dissociation. The principal motion, as you can see, if you have this movement, is flexion and extension, and a little lateral bending and rotation is possible. Flexion extension is up to 24 degrees. Flexion is stopped ultimately by contact between odontoid and the occiput, while extension perhaps by the tectorial membrane. Atlantoaxial joints, or C1, C2, are anterior synovial joints between dens and C1, so between dens and C1 itself. And there's a posterior synovial joint between dens and transverse ligaments, so it's in front and back. And there are two lateral C1, C2 joints, as you can see here. Primary motion is rotation, so we are able to rotate, so 38 degrees to one side, accounting for about 80% of the total axial rotation of the cervical spine happens on C1, C2, and it's a very important joint for us to look around. Odontoid process acts as a pivot for rotation. So on pivot, it rotates about 40 degrees on each side. What about the ligaments? These are very important, and we need to know and understand them. So if we just look at this anterior longitudinal ligament, it goes up, becomes the anterior atlantoaxial ligament, and then goes up all the way and then is connected all the way onto the bone on top. Whereas the posterior longitudinal ligament, as you can see here, goes up, turns around, and becomes the membrana tectoria, and it has its two superficial and deep membrane. Then we have the apical ligament, which is coming from the dens itself and going up, and we will see this in detail. And also, then you have the transverse ligament, which is shown here, and which we will see in detail. The transverse ligament is extending, going up, and then going on two sides, and we'll see in AP and lateral images in detail. The ligaments, if you look at from behind, then you remove the lamina, then you see tectorial membrane, and it's continuation of the posterior longitudinal ligament, superiorly above to C2, and covers the dens and the transverse ligaments, and it attaches to the close and to the medial border of the occipital condyle. The important ligament is cruciform ligament, and it's basically an anatomical seat belt, and you can see it's restraining the dens which is behind us. And it has the transverse and vertical parts, as you can see here. Transverse ligament is thick, strong band that arches across the ring of the atlas behind the dens, which is seen very well over here. It is really thick in the middle and attached to the tubercle on the medial surface of the lateral mass of axis. Its acts as an anatomical seatbelt, as we talked about it. And then there is LR ligament on both sides going up. These are very strong ligaments going from apex of the dens to the medial aspect of the occipital condyle, as seen here. Let's see on this nice atlas that I have. So if you look at these things, first of all, we have this nuchal ligament in the middle. Then we come to posterior atlanto-occipital membrane. When we hide that, then we come across longitudinal fasciculus of cruciform ligament, then the transverse cruciform ligament. And then if you remove that, you see the apical ligament in the center and alar ligaments on both sides. And if you look behind, there's anterior occipital membrane. And if you follow that posteriorly, there is anterior longitudinal ligament. So you can see these going from top to bottom. You can see how vertebral artery comes through, turns around, and then comes medially and goes up into the foramen magnum. And obviously there are other structures, but we can see them in the next image. So vertebral artery goes through, in majority of the cases, comes from C6, turns upwards, turn around, take a loop, and goes back up. And this loop is important so that we can have movements of our neck when required. For whatever reason, if there is an osteophyte there, then we can run into trouble. Posterior approaches to occipital cervical membrane. So where do we use them? It's in trauma, type 2 and 3 odontoid back fractures, type 2 with oblique fractures in the frontal plane with significant displacement associated Jefferson fractures, type 2 patients with large kyphosis and barrel chest where we can't put in an anterior screw because of the chest is coming in our way of the trajectory of the screw. Then type 2 in elderly patients where there's non-union, pseudoarthrosis after immobilization, and congenital malformation in orthodontum, with that we routinely do that in agenesis. First of all, posterior wiring described way back by Galley in 1939. So you can imagine what we were doing at that time. It offers good stability in flexion and extension. It's very good. But because of poor stability and rotation, it's not used on its own, or it's not used generally with the new gadgets that we have. Sontag modified this and added sublaminar wires and then notched ilia crest between C2 and wedge under C1. Edges were decorticated prior to placing the autograft and recommended a halo or a rigid collar after that. So basically, your cable comes underneath the C1 and we roughen it out. We take this particular bone and then we can put in this bone by making sure that there is raw bones on both sides. Then you bring the loop around and tie it and tighten it, and it will hold. Obviously, this alone doesn't work, and it is used routinely with the screws if you want to have further good fusion in these patients. The important parts of anatomy for C2 is to differentiate between pedicle and the pars. So if the pedicle, if you look at, is between the body and the pars itself, so it's all the way medially. Whereas if you see the pars is the structure that obviously is between the two anterior and superior part of the joint itself. And we need to just remember this, that it's important if you have to put in a pedicle screw, obviously it's going to come all the way like that, whereas pars screw will take you straight up 10 degrees or 15 degrees. Let's first go through transarticular screw. The entry point for transarticular screw is same as a pars screw entry point. And that's the direction that then we take. McGrill and Jenner, I ended up seeing a workshop or attending a workshop with them in late 1980s. It was amazing to see them work. So for them, it completely obliterates the rotational motion. It's very good if you're good at it. The problem is disadvantages. I generally don't use it because there's a steep learning curve and potential complications of screw misplacement, hardware failure, and hypoglossal nerve injury. And most importantly, vertebral artery injury described in about 25% of the cases in some series. So you have to be very careful about it. And for that, you need to have a preoperative CT. Anomalous vertebral arteries need to be seen. Bone destruction, how much of bone is involved, if the pedicle is too small. And then you also need a preoperative MRI to assess degree of neural compression and transverse atlantal ligament if they are intact or not. And then depending on that, obviously you decide. So you have that screw that's going up all the way, which are transarticular screw. Which if you keep them short, then it automatically becomes a par screw. Transarticular screw technique, entry point is C2-3 facet joint or just above that. K-wire is directed 15 degrees medially, aiming at the anterior tubercle of C1 on fluoro. Care is to avoid drilling beyond the arch of C1 into soft tissue. And why is that? There are structures there, and we'll see that shortly. This procedure is repeated on other side, and then rigid collar for 3 months. C1, C2 transarticular screw. So the most important thing is you can't put it if your C1, C2 are not in alignment, and obviously you'll end up hitting the vertebral artery in serious problems because we need to go above the artery, and for that you need to have both C1, C2 in alignment. So transarticular screw, basically the entry point is if you take midpoint of medial to lateral, so somewhere there, and going all the way up, and then goes upwards 3 millimeter from the lower end, and then your direction is going to be approximately 50 degrees cephaled, and you're going towards the C1, C2 joint, going through that and working your way upwards into the dens itself. This kind of trajectory you need, so that's why there's a problem if you have a Barrett's chest. Then if you have an issue with some kind of fusion in the bones, then you may not be able to do this. If it's not aligned back, then it's a problem. So the entry point is something like that and going upwards, and the direction is very steep. And this is the kind of fusion and screw that you need to see, and we just need to put in a lot of bone around it. Yeah, we look at another case, a 28-year-old, history of fall from first floor, complaining of neck pain and bilateral upper limb weakness. Was Asia A, had cervical contusion, secondary traumatic C2 vertebral body fracture. C1, C2 posterior fixation was done with C1 lateral mass and C2 translaminar screw. So this is the kind of fracture that patient had with a contusion, and patient underwent surgery. This was the MRI with a contusion in the cord here. And this is the kind of fusion that you get through fixation once you put in C1 lateral mass and C2 translaminar screws. C1 lateral mass and C2 parts or pedicle screws are described by Harms in 79. Advantage anatomical alignment of C1, C2 is not necessary. You put in these screws separately and then bring it back. Also, it may be used in the case of aberrant vertebral artery. Disadvantage is potential for significant blood loss when you're dissecting the C2 root. If you're doing it for the first time, you may have it, but once you're used to it, it's much easier. You take a piece of spongistan and a patty, and then dissect with the help of your Watson chain and bring it down, and it's much easier to do that. Put a peb, leave it packed on one side, go on to the other side, do that side, and by the time you come back to the first side, then it's hemostasis is already achieved, and it's very easy to put in the screw, as I will show you later. So you have something like this, in which you have got all this venous sinusoids, and what you need to do is you need to just dissect with the Watson chain from here and work your way down. The nerve is coming down here, and the ganglion is just here in relation to C1 root. The entry points there are 3 types. The conventional entry point is right in the middle of the lateral mass. The second is obviously the arch screw, which is going into the arch itself. And the third is the notch screw that is going into the notch itself. So, so these 3 types of screws. The arch screw is tricky because if the vertebral artery has a loop there up on the top, then you can cause problems. Notched and direct point are much easier to put in. So it's Harms reported with the use of polyaxial screw and rod system in 2001. So Goel and Harm technique is what it's called, because Goel described much earlier to Harm. Advantage: anatomical alignment of C1, C2 may not be necessary. Disadvantage: potential for blood loss. It is less rigid than C1, C2 transarticular screw, but still in the long run, the outcome are nearly same. These are the three methods that were described. So Goel described in 94, which is the direct approach, and then going directly onto the bone itself. And then it's very simple because big, thick piece of bone in front of you. So all you need to do is 15 degrees to 10 degrees medially, and then going into and hitting the tubercle in that direction. It's much, much, much easier. The important thing to understand is that, you have got bone coming at an angle here, and this area here is very important for us. As the carotid arteries, there is a hypoglossal nerve there. So you can't be going in front of that, otherwise you can damage that. For the TAN screw, which is a translaminar screw, going through the lamina itself, but the problem could be that the vertebral artery could be endangered. The notch screw is quite simple as well, and there's not much difference between that and the Goel's technique. The anterior relations, as I talked about, you can see the hypoglossal nerve, the carotid, internal carotid there. And this is the area which is important that I'm talking about. So you don't want to be going in front thinking on the notch on the lateral C-arm that you're all right, because you'll end up causing grief to the red structure or to the hypoglossal nerve in that area. So it's very important to stop short in thinking that this kind of angle that we have in front. So let's just quickly show you through one surgery. So we are dissecting through, trying to put in for this the laminar screw first. So we made an entry point here, and we use the drill, go all the way onto the lamina onto the opposite side. The other screw is going to be inferior and lateral to it, so it will be going in from this direction, working our way down. The one is higher up, one is lower, one is superior, one is inferior. So it is much easier. So we put the second screw, which goes in front of it and not hitting the two screws. And then we put in our simple Goel's screw going into the lateral mass, which is a thick piece of bone in front. And one side and now the other side. So we drill, and that's the entry that we have made, and then the screw going in. So it is very, very simple, and you join them together. So it's generally speaking, the transarticular screw are quite risky because of the vertebral artery being aberrant or causing problems, and 1 in 4 patients could run into trouble. The power screws are relatively safer, but you stay short, doing exactly the same thing, but you're going and staying short, so something like that. And the pedicle screw obviously goes all the way medially, but you have to study and make sure you study. And if you're using image guidance, it's much easier, but if not, then you need to open up the lamina a bit and have a look that you're in the right direction and not hitting anything else or not hitting important structures in that trajectory. The C2 laminar screw are the safest to put in because there is no vertebral arteries nowhere near, and you can put up to 30 millimeter of screw in there. Again, let me just revise. C2 pars is between the superior and inferior articular processes, and trajectory similar to C1's C2 transarticular screw. Entry point is 3 millimeter rostral and 3 millimeter lateral to the inferior medial aspect of the inferior articular surface of the C2, which is here, and goes up and stays short. So it's about 12, 14, 16 millimeter screw, not going above into the dodgy areas. And for pedicle screw, so basically let's stick to par screw. So it's 40 degrees or more going in this trajectory and then staying short. So something like that, but stopping short, so you don't want to be hitting the artery itself. The C2 pedicle, as I said, connects with the body with the pars, and the entry point is 2 millimeters superior and 2 millimeter lateral to the entry point of C2 par screw, which is somewhere here. So this goes up, but the direction is quite medial. And for that, you can see the difference between pars and pedicle screw, the directions as shown here. So this is the pars and this is the pedicle. Laminar screws are easy to put in. As I said, you start at the spinolaminar junction. So one screw, you look at both sides. One side is usually higher than the other. For example, here, the side looks lower than the other side. So this one then obviously starts from the top and anteriorly and work your way down. This one then starts posteriorly and work your way down in this direction. Average, you can put up to 3 centimeter screws. They are each very, very simple to put in, but you need to have understanding of where you want to come. So generally speaking, it's okay to come out with a screw or the grooves coming out here. We don't mind that, but as long as we are not going in this trajectory, it might be a good idea. So you can see then same, we can do C1 lateral mass and C2 laminar screws for these patients. They're very, very low risk. So we have to choose wisely when we are doing this and trying to avoid the vertebral artery at the same time, trying to improve the outcome. The most important bit is when you're putting in at the end, when you have got, for example, something like that, so you don't have straight rod coming in, so you have a curved rod and you basically distract this. And once you distract automatically, if you've got basal invagination, it will automatically reduce. So it is very, very simple to use. And basic concept is that you use biomechanics to your advantage. Keel plate fixation, when we do occipital cervical, we know that the thickest point is right in the middle here, and you aim for bicortical purchase. So use a drill and at the same time have some bit of bone wax, and you see if a little bit of CSF comes out, it's not a problem. Multiple short braided blunt tip screws prevent the plate rotation. If the occipital decompression has already been done, then it's a problem. Obviously, you can't do that. But this is selected for only those patients where there is instability in the occipital cervical junction, and on top of it, it's not C1, C2 can't sort the problem out, which in majority of cases it does. So all those patients we thought that we would not be able to reduce, now we are able to reduce. So before I wrap up, I invite you all to the WFNS educational course. This time it's in Karachi from 24 to 26 January. Already 22 experts will be there in different specialities and subspecialties with hands-on spine robotics course, endoscopic skull-based course, peripheral nerve, and vascular course. So the 4 courses will be there. Professor Zalili and Greg Frost from USA would be also helping us run this course. So thank you very much, and it was really my pleasure to be here.
Thank you very much, Professor, and thank you for this nice presentation and very nice surgeries. We'll see if anyone have any questions or any something to ask Professor Salman Sharif. Professor Salman, I have a question for you, please.
Sure.
Regarding the translaminar screws, you said the length usually is 3 centimeter. How about the diameter? How much you usually use?
Usually there's 4 millimeter screw, but what we do is we study the laminar beforehand to make sure that it's thickened enough. There are some patients who would have very thin laminar and difficult to put in. In those, we use 3.5 screws, but what we do is we try to come out with the grooves on the outer aspect so we can see it on the lamina itself. The grooves are seen. So we don't mind that, but because it's a cortical surface on both sides, the strength is very, very, very good.
Great. If we have, in some cases, there is some C1, C2 subluxation or dislocation, how we do in these cases?
Same. I think because it's so safe putting in translaminar screws, I've stopped using pedicle screws in C2. And it's much easier because, I use 3 theaters when I'm operating. So I have my SRs and residents working there. And it's so easy to use that you can trust, it's very, very simple technique. So I would do exactly the same thing in those. And the only trick is when you're distracting, then you have to have a curved hockey stick way of reducing, because when you distract, automatically the invagination goes up, or C1, C2 subluxation reduces. And it's very, very simple concept.
Thank you very much, Professor. If anyone have any question for Professor Salman Sharif? Okay. I don't see any questions. So thank you very much, Professor, and we appreciate your help and your support to the Yemen Neurosurgical Society. You always support our activities and our webinars. So thank you very much, Dr. Salman.
It is really our pleasure, and Pakistan Society of Neurosurgeons, it's our pleasure there as well. World Federation is honored that you guys are doing such a good job. Anywhere where there's education, we'll be there to help you. Don't worry.
Thank you very much, Professor.
You're welcome.
So now we can move to our next speaker, Dr. Emmanuel Bor. Dr. Emmanuel.
Yeah, thank
Dr.
you.
Emmanuel, how are you? Do I
I'm
pronounce
good.
your
I'm
name
good.
correctly?
Yes, Professor.
Okay, thank you. Dr. Emmanuel, he will talk today about vertebral column anatomy, sacrum, and the coccyx, and the
Yeah.
classification, fracture classifications. Dr. Emmanuel is a spine surgeon at the Department of Neurosurgery, Krishna Institute in
Yes.
India. Doctor, please, you can go forward.
Yeah.
Can you share your screen, please, Professor?
Yes, please. Just a second. Yeah.
Okay, that's good. If you can
Thank you
make
so
it in
much.
full. Okay, great.
Yeah. Thank you so much for the invitation. And the topic for that has been given to me is the anatomy of sacrum and coccyx and their fracture classification. Usually in our practice, we do not encounter much of sacrum and coccyx fracture. But nevertheless, I mean, we'll be talking mainly basically the theoretical aspect of the sacrum, coccyx, and fracture classification. Now, this is the overview. What I'll be talking about is embryology of the sacrum, anatomy of the sacrum, embryology of the coccyx, anatomy of the coccyx, and the fracture classifications. Now, if we come if we talk about the embryology, I mean, before talking about the embryology, the word sacrum, it comes from a Greek word, hirion osteon, which means holy bone or the sacred bone. And the sacrum, as we know, the ossification centers, the primary ossification centers, there are mainly three: one for the center and the other for the two neural arches. Now, the first for the S1, S2, and S3, the ossification center appears around 9 weeks. For the S4 and S5, it appears about 24 weeks. Now, during that time, around 24 to 34 weeks, there are others centers, 6 centers, which appear for the sacral ali, as is shown in this picture, and the arrows are pointing towards the ossification centers of the ali. There are also accessory and which are also called as secondary ossification centers for the upper and the lower end plates. And once these ossification centers appear, the sacrum usually starts fusing by the age of adolescence, maybe 14 or 15, and then the complete fusion takes place at the end of the third decade. Now, coming to the anatomy of the sacrum, it's a very complex bone, which is an inverted triangle, and it's curved and tilted backwards, which it has 4 surfaces: the anterior, the posterior, and the two lateral surfaces. The anterior surface is mainly concave and is smooth, and it has 4 ridges, as shown in this picture, which are the remnants of the intervertebral disc. On the lateral aspect of ear are these neural foramen or the ventral foramen, which are broader than the dorsal foramen for the exiting of the sacral nerve roots. And anterosuperior, as we see here, there's a prominence which is called as sacral promontory. Now, if we come to the posterior part of the sacrum is very rough compared to the anterior. It has this facet articular process. Then in the center and just lateral to it, there are 3 crests. The median crest, which is formed by the spinous process of the sacrum. Then there is a intermediate crest, which is formed by the fusion of the articular process of the sacrum segments. And then there is a lateral crest, which is formed by the fusion of the transverse processes. Now, if we look at the articulations, sacrum, base of the sacrum, it articulates with the L5 vertebra through the L5S1 joint and the intervertebral disc space, while the apex, it articulates with the coccyx, forming the sacrococcygeal joint. Posteriorly, the vertebral canal, it continues as the sacral canal, which ends as sacral hiatus at the level of S4. Now, coming to the muscle attachments, now this is the ventral surface or the anterior surface, which is smooth. The muscle, if we take a look at this picture, there is a piriformis muscle which is attaching on the just lateral to the neural foramen, and this piriformis, again, we know it attaches to the greater trochanter, which is the external rotator of the hip. Then there is a few fibers of the iliacus which are attached or take their origin from the sacral ali. And then there is a coccygeus muscle just distal to the piriformis muscle, which is attached on the lateral surface of the sacrum and the coccyx. Now, this is the posterior surface of the sacrum. Now, regarding the posterior surface muscle attachment, here in the center, just to the medial to the crest, we have the multifidus, which is a deeper muscle. Then just lateral to the multifidus, there are superficial muscles, the rectus spinae muscles or the spinalis. And then we have the gluteus maximus, which is just in the caudal region of the sacrum or the posterior aspect, dorsal aspect. Now, the blood supply to the sacrum comes from the medial sacral arteries and veins. Medial sacral artery, again, is a branch straight from the abdominal aorta. And the two lateral sacral artery, these are the branches of the internal iliac artery. The veins, again, they drain back to the internal iliac and the common iliac. Regarding the lymph nodes, there are pre-sacral lymph nodes, again, which receive lymphatics from the rectum and the posterior pelvic wall. What is the function of the sacrum? When it comes to the function of the sacrum, it acts like a support for the upper body, and it helps in distribution of the weight across the axial and the appendicular skeleton. Clinical significance wise, there can be a metastasis from the pelvic organs. Then sacrum itself can be a primary site for the carcinoma. And there are sacral stress fractures, which are commonly seen in athletes. And there is an insufficiency fracture where the bone is diseased, and just a trivial trauma causes a fracture, which will be seen in the osteoporotic bones. And there are traumatic fractures, which are due to the high energy trauma. Coming to the coccyx, it's derived from a Greek word coccyx, which means cuckoo, or because the shape of the coccyx is like a beak of the cuckoo, it's called as coccyx. Again, the coccyx, it has only one ossification center for the body. So it appears by the first year, and subsequently the other segments ossification centers start appearing, and the fusion starts by the end of second decade and is completed at the end of the second decade. This is a picture showing the anterior and the posterior surface of the coccyx. If you look at the first segment of the coccyx, it has a body here. The blue is the transverse process of the first segment. The green is the articular surface, which articulates with the sacrum S5 segment, forming the sacrococcygeal joint. And the yellow is the cornu of the coccyx, which articulates with the cornu of the sacrum, that forms the sacral foramina for exiting of the S5 nerve root. The remaining three coccyx segments, they have a body and the remnants of the transverse process. Again, the articulations wise, it forms the sacrococcygeal symphysis of the joint, which is fibrocartilaginous joint, and the sacral foramen, which is formed again by the fusion of the articulation of the cornu of coccyx and the sacrum. Ligament-wise, there are ligaments: anterior sacrococcygeal ligament, posterior sacrococcygeal ligament, which has 2 layers, superficial and deep, and the lateral coccygeal ligaments. Coming to the muscle attachment, again, coccyx, it gives attachment to 3 important muscles: the levator ani, which is attached at the center of the coccyx. On the ventral surface, or the ventral and anterolateral, is attached the coccygeus, and on the dorsal surface is the gluteus maximus, few fibers of the gluteus maximus. This coccygeus and the levator ani, they form the muscles of the pelvic floor, which helps in supporting the pelvic organs. Again, the blood supply, the lymphatics, is similar to the sacrum, from the medium sacral artery and vein, and the lateral sacral artery and vein. The nerve supply for the coccyx is through the coccygeal plexus, which is formed by the S4, S5, and the coccygeal nerves, along with the dorsal rim of the sacral sympathetic trunk. Movement-wise, if you take a coccyx, mainly the movement occurs at the sacrococcygeal joint. It's mainly during the sitting and the standing position, and also during labor. Basically, the coccyx moves posteriorly, so that the space available for the passage of the baby is enlarged. And for post labor, again, the coccyx is brought back into the position as it moves anteriorly. Function wise, as we know, it gives attachment to the important structures, mainly the muscles, the levator ani, and the muscles of the pelvic floor, which support the important structures and the anal sphincter. The final terminal, again, it's an extension of the pia mater from the lower part of the conus medullaris, and goes and attaches to the coccyx. Coming to the sacral and the coccyx classification, fracture classification, there are different classifications. Like first, it was the Roy-Camilli classification, which described only they described about the included only the transverse fractures of the sacrum, the coccyx. Then it was the Eiler and the Gans, which took into consideration the L5S1 joint and versus the spinopelvic stability. And the more common classification that we use is the Dennis, where the Dennis described the 3 zones: the zone 1, which is lateral on the sacral iliac; the zone 2 along the neural foramen; and the zone 3 in the center of the sacrum. The Caro et al., they clubbed all the horizontal and the vertical fractures into group. But the problem with this classification system was that they did not cover the entire spectrum. There was a low inter and intra-observer reliability, and they could not anticipate the prognosis. So that is where the AU classification was brought in, which is CT-based, and this helps in communication with one another. It serves as a common language for all the surgeons across the world. It also helps in defining the prognosis after the injury or treatment and describes trend patterns. Now, AO classification, it takes into consideration 3 criteria. Basically, the morphology. Second one is the case-specific modifiers, and third is the neurological injury, as we've seen in the thoracolumbar fracture classification and the cervical subaxial fracture classifications. Morphology-wise, the type A is the lower sacrococcygeal fractures, type B are the posterior pelvic, and type C are the spinopelvic. This is a picture that shows, explains the classification system, where type A is the lower sacrococcygeal injuries, which means the fracture line is below the sacroiliac joint. So this is further divided into A1, A2, and A3. So A1 are the coccygeal or the sacral compression fractures, or the ligamentous avulsion fractures. A2, these are the non-displaced transverse fractures, below the sacroiliac joint. And A3, these are displaced transverse fractures below the sacroiliac joint. When we look at the type B fractures, these are the posterior pelvic injuries. That means the fracture line is lateral to the L5S1 facet joint, so that it doesn't cause any spino doesn't include the spinopelvic instability fractures. So B1 is a fracture which is lateral to the L5S1 facet, but just medial to the neural foramen. These are unilateral vertical fractures. And again, B2 is a transalar fracture, again a vertical fracture, but which is lateral to the neural foramen. And then there is B3, which is through the neural foramen. Now these the B-type fractures, they remind us about the Dennis fracture classification, which are described zone 1, which is similar to B2, zone 2, which is similar to B3, and zone 3, which is similar to B1. When the fracture is in the zone B2, that is the transalar, the chances of neurological injury are only 5%. Here, mainly the L5 nerve root gets injured. It's because of the displacement of the sacral ali, and the nerve root gets trapped between the sacral ali and the L5 transverse process. When it comes to B3, that is the transforaminal, the chances of neurological injury are around 25%, 25 to 28%. And when it comes to B1, the chances of neurological injury are around 68%. Coming to the type C, which describes the spinopelvic injuries. Now, the difference between type B and type C is the fracture line is just medial to the L5S1 joint. That is, there is a disruption of the L5S1 joint. And that is why these fractures are included in the type C, which cause spinopelvic instability. Now, there is a C0, which is non-displaced sacral U-type fracture. Now, this fracture is included. These are basically the insufficiency fractures, which occur due to the osteoporosis. C1, it's again, these are B-type fractures. C1 is again B-type fractures. That is, these are vertical fractures, but the fracture line is again medial to the L5S1 joint. So this causes the spinopelvic instability. C2 is bilateral vertical fractures, which cause spinopelvic instability. And C3, these are displaced U-type sacral fractures, maybe U-type or H-type, which again cause spinopelvic injuries. Now, there are patient-specific modifiers which are included in this classification, where M1 is the substantial soft tissue injury. M2, it's mainly the metabolic bone disease. M3 is the anterior pelvic ring injury. And M4 is the sacroiliac joint injury. These are associated injuries along with the sacral fractures. Then there is a neurological component that is included here. N0 is the intact neurological status of the patient. N1 is transient injury. N2 is non-transient nerve root injury, which usually involves the L5 and the S1 nerve root. And N3, it includes the quad equina injury. Now, again, when this classification, what are the drawbacks or the limitations of this classification are? The inter-observer reliability for the classification of the fracture type A, type B, type C, it was substantial. Now, this is based on the kappa values, where if the kappa value is around 0.6 to 0.8, it's substantial. More than 0.8 is almost perfect. So the inter-observer reliability was almost perfect. But when it came to the subtype of the fractures, the A1, A2, A3, or the B2, B1, B2, B3, C1, C2, C3, the inter-observer reliability, it was moderate. That is, it was less than 0.6. And the inter-observer reliability was around, it was almost substantial, that is 0.8. So since the inter and the intra-observer reliability it's not very reliable, so when the subtypes were taken into consideration, it became difficult to understand these fractures and manage it, plan a treatment protocol for these patients. Now, another thing was the modifiers, which we discussed, and the neurological injury. Again, it was not subjected to reliability. Again, this AO classification, it did not describe the degree or the displacement angulation of the fracture. And also, if you look at type C, the C0 C0, which is an insufficiency fracture, which occurs mostly due to the osteoporosis of the bone, was included in the type C fracture. Now, if you look, type B is a more severe injury. Type B1 or B2 is a more severe injury than type C0, but still type C0 has been included in the type C classification. So that was another drawback of this classification. And again, if there are the lower frequency of some fracture patterns were observed, for example, when the Vaccaro et al., they did a study, they found that most of their fracture, the A1 type fractures, the number of A1 type fractures that they got in the study were less. And this affected the inter-observer and the intra-observer reliability. So these were the drawbacks and limitations of these classifications. Yeah, that's it. Yeah. Thank you. Thank you so much.
Thank you very much, Dr. Emmanuel, for this nice presentation and nice clarification of the classification system of the sacral fractures. We'll see if there is anyone have any questions in the chat, or if anyone can ask directly Dr. Emmanuel. I don't see any questions. Dr. Emmanuel, according to your experience, how many cases do you face like this in the real world? Do you
The sacral
usually manage it?
fractures were very less common, but most of the fractures which were undisplaced were managed non-operatively. We hardly get, sacral and coccyx fractures in our practice. It's mostly the thoracolumbar region and the cervical spine injuries where we get the dislocations and the burst and other fractures. Sacral fractures are not very common here, at least in our practice.
When we have sacral fractures, usually you do it or orthopedic surgeons do it?
Actually, I'm an orthopedic surgeon, orthopedic spine surgeon.
Oh,
I do have a,
okay, okay.
I do have a, I'm working in neurosurgery department. So we do have neurosurgeons around. So as a team, we work together and make a plan for these fractures. But mostly,
go on, continue, doctor.
Yeah, that's it. Most of our patients, most of the fractures that we get here are mainly thoracolumbar regions and the cervical trauma.
In our practice, usually they are different departments. Neurosurgery are different from orthopedic department, and usually sacral fractures are usually managed by orthopedic surgeons, not by us. We usually take care more of the thoracolumbar and cervical, as you said.
Okay.
Okay, so thank you very much, doctor. I see there is no questions. If anyone want to ask any questions, okay. Thank you. It's looks like there is one question here by Dr. Muhammad Awad. Does Bennett's formation at C2 in patient with Down syndrome lead to instability? This is not related to our subject. If you would like to answer.
Sorry, I didn't get you.
He's asking about C2 Bennett's formation in Down syndrome. This is unrelated to our subject today. So I don't
the
think,
C2, I think that because of the pannus basically it causes erosion and erosion of the bone, and because of the on top of that, if there is a Down syndrome, there'll be ligamentous laxity, which results in the instability of the C1 and C2 joint. So it does cause erosion of the bone and instability.
thank you. So I think there is no more questions. So thank you very much, Dr. Emmanuel, for your
Thank you so
presentation.
much. Thank you so much.
Thank you for your support.
And the opportunity. Thank you.
Okay, you're welcome, Dr. And we are thanks to you. So by this, we conclude our last webinar of the Comprehensive Neuroeducational course. We should have another presentation by Dr. Victor Hugo Beres, but unfortunately he was not available and he could not join us. So maybe we can do it in another webinars. So for all the participants, all those who fulfill the minimum requirements of attendance will be given a certificate of attendance in this few days, 1 week in maximum. And where I take this opportunity also to invite you all to attend the 6th Yemen Neurosurgical Conference that will be held in November 27th until 29th. The announcement will be sent in WhatsApp to the groups, and also the registration and Zoom registration also will be sent. So thank you all for attendance, and thanks to all speakers. Thank you, Dr. Manuel, and thanks to the Professor Salman Sharif also, and to all speakers who assist in the success of this comprehensive educational course. So really thank you, Doctor, and thanks to all attendants. Thank you very much.